A very warm welcome to all of you. We are at the Department of Radiation and Oncology, Government Doon Medical College, Dehradun. Today we will discuss the role of adjuvant Transtuzumab for Her2neu receptor positive breast cancer treatment. In the discussion session, I am Dr. Lalit Mohan. I am Assistant Professor and in charge Department of Radiation Oncology. Along with me, we have Dr. Richa Gupta, who is Senior Resident, and Dr. Gaurav Sharma, who is also Senior Resident. Dr. Gaurav will present all the fine details of HER2 positive breast cancer and the treatment and mechanism of action of Transtuzumab. Over to you, Dr. Gaurav.
Today, good morning to all respected teachers. Today, I am presenting the breast cancer management. The incidence of breast cancer is highest in females in India. The management of breast cancer include surgery, followed by adjuvant chemotherapy, followed by adjuvant radiotherapy. In locally advanced and early breast cancer and locally advanced, it is divided into early breast cancer and locally advanced breast cancer. So in early breast cancer, the primary mode of management is surgery, and according to the poor prognostic factors, adjuvant treatment is given. Similarly, in regionally advanced breast cancer, the initial management is chemotherapy followed by surgery and followed by chemotherapy, followed by radiotherapy and hormonal treatment. In the same line, when we give adjuvant treatment, it is based on prognostic factors, which is hormonal receptors and Her2neu receptor. So in Her2neu, today we are discussing the adjuvant treatment according to the Her2neu receptor status, for which immunotherapy is given, which is Transtuzumab. Now going to the detail of Her2neu receptors and what is the mechanism of action of Transtuzumab in adjuvant treatment. So Her2neu receptors are divided into there are 4 family of HER2 receptors. The HER2 receptor is considered as a poor prognostic factor in breast cancer. So it is divided. HER2 receptors are divided into four types of receptors: EGFR HER1, HER2 ERB2, HER3 ERB3, and HER4 ERB4. All her receptors are involved in breast cancer except HER4. The her EGFR, HER2, and HER3 are overexpressed in 30 to 40%, 20 to 30%, and 20% of breast cancer. Now going to the mechanism of action of HER2 receptors. There are 4 types of HER2 receptor, as I discussed: EGFR, HER2, HER3, and HER4. The most commonly which is involved in breast cancer is HER2, though others are also involved, but they have no significance in management or little significance in management. HER2 receptors work by homodimerization and heterodimerization. In the so what is the principle of this mechanism of action? Principle action of this HER2 receptor. They are considered as poor prognostic factor, as I discussed. They are involved in proliferation, differentiation, apoptosis of the cell. When this HER2 receptor is blocked, there is inhibition of proliferation, differentiation, and apoptosis. How it blocks? There are different ligands: epidermal growth factor receptor, TGF alpha, amphiregulin, and epigene. Similarly, other ligands like epiregulin, beta cellulin, HBEGF, NRG1, NRG2, NRG3, and NRG4. These ligands bind to HER receptors at different sites. So EGF1 bind amphiregulin and epigene bind to EGFR. Epiregulin, beta cellulin, HBEGF binds to all EGFR, HER2, HER3, and HER4. by binding to an NRG1, NRG2, NRG3, and NRG4 bind to HER4. By binding these ligands to HER2 receptors, they causes the inhibition, activation of pathways like STAT pathways, PI3K pathways, RAS pathway, PLC pathway, and SRC pathway. These pathways cause proliferation, differentiation, and apoptosis by particular mechanism. So this is the mechanism of HER2 receptor. Trastuzumab acts at this HER2 receptor by inhibition of all these pathways. So there is inhibition of proliferation, differentiation, apoptosis, and motility of cells, causing inhibition of tumor proliferation. The Transtuzumab was approved in FDA in 1998 and has been a game changer in breast cancer in adjuvant treatment. Overexpression of HER2 receptors transform cells, which I have discussed earlier, and it is a poor prognostic factor. The HER2 receptor has transmembrane protein, are single transmembrane protein which have N-terminal extracellular domain and a transmembrane helix and cytoplasmic domain. The extracellular domain, which is a major action of HER2 binding drugs, contains 4 subdomains. Domain 1 and domain 1-3, which is ligand binding subdomain, and domain 2 and domain 4, which is receptor dimerization subdomains. So Transtuzumab acts to the domain 4 that is close to HER2 juxtamembrane region. So the summary of mechanism of action is that it is mainly the main action of Transtuzumab is on antibody dependent cell mediated cytotoxicity, which means that when the Transtuzumab acts on the receptor, it initiates the cell mediated cytotoxicity, which is the extracellular action of Transtuzumab. Other action of Transtuzumab is also intracellular action, which includes inhibition of HER2 mediated cell signaling, inhibition of cell HER2 cleavage, inhibition of angiogenesis, and inhibition of DNA damage repair. These intracellular action has not been studied much and has limited data. But the main action, which is antibody dependent cell mediated cytotoxicity, is the major action of Transtuzumab, and it is well studied. Now, continuing with the adjuvant treatment of Herceptin based treatment, now we are discussing some trials associated with Transtuzumab. This is a landmark trial of Transtuzumab which is published in NEJM in 2005 and has a major revolution in management of HER2 receptor based treatment in breast cancer. As I discussed, the management of breast cancer include adjuvant chemotherapy, which is decided according to the hormonal status and HER2 based receptors. So this trial is funded by Roche and is completed in 2005. Now this trial included whatever myths was earlier that Transtuzumab is to be used or not, but it cleared the myths and has and shown that Transtuzumab should be included in the management of adjuvant chemotherapy. The trial is conducted in Europe and included 1694 patients, and in which it is randomized into this is the schematic diagram of this trial, in which the patient taken in this trial are HER2 positive, which is to be determined by biopsy, and HER2 receptor status. These patients are included. As I discussed, the primary treatment in this trial, all patients are taken in whose treatment are underwent surgery followed by adjuvant or neoadjuvant chemotherapy, or with or without radiation therapy. The patients which are taken are who had undergone surgery and who had taken adjuvant treatment or neoadjuvant treatment, or had taken radiation therapy. They are also included, because sometimes during radiation also some concurrent role of Transtuzumab is seen. So these patients are also taken in this trial. The confirmation of HER2 positive status was done by FISH's functional in situ hybridization, which is read by IHC 3+, which is known as HER2 3 positive tumors, which are included by this test. Then the inclusion criteria is the patient has ejection fraction which should be more than 55%, which is the inclusion criteria in this study. The patient were randomized into 3 arms: 2 years of Transtuzumab, the 1 year of Transtuzumab, and observation arm. The dose of Transtuzumab, which is the loading dose, is 8 mg per kilogram body weight, followed by maintenance dose of 6 mg per kilogram every 3 weeks for 2 years. Each arm is equally matched. In this arm, 1694 patients are taken. In 1 year of Transtuzumab, same dose is given for 1 year, and around 16 same patients are taken. In observation arm, there are 1693 patients, and follow-up of 36 months was done. In 2 year arm, the 128 disease-free survival events is to be expected, and patient was kept in strict follow-up. Similarly, in 1 year Transtuzumab, 127 disease-free survival events to be expected, and follow-up was done strictly, and same in observation arm. These are baseline characteristics, which are both arms are equally matched, and this is the table showing what are the characteristics in this trial. What are the basic patients taken are what category and what histology they are taken, how much what surgery is done, and radiotherapy is done. Both arms are equally matched. Most of the patients are of poorly differentiated tumor, around 1115 in 1 year Transtuzumab arm and 1012 in observation arm. In surgery, the most of the patients have mastectomy MRM patients. In 1 year Transtuzumab, 972 patients, and observation 987 patients, and most of them had taken hormonal treatment also. Similarly, this is the chart showing adverse features. Most of the patients have in 1 year Transtuzumab have side effects of cardiac events, most having cardiotoxicity, cardiomyopathy, and congestive heart failure. Serious adverse events are seen. Patient with grade 3 or 4 events are seen in 7.9% of patients in 1 year of Transtuzumab arm compared to observation arm, which is significant, p-value less than 0.001. Similarly, at least one serious events are seen in 7% of patients, which is also significant. This is a chart showing disease-free survival in both arms. Most of the cases, there is a significant benefit of recurrence, second primary event, or prior recurrence in 1 year Transtuzumab arm, which is 7.5% in Transtuzumab arm as compared to 13% in observation arm. The most of the Transtuzumab has a major most of the benefit is seen in the distant recurrence arm, in which 5% of the patients show has distant recurrence decreased as compared to observation arm. There is no benefit of Transtuzumab in central nervous system. This means that in brain mets it has not worked. This shows that there is maybe the cause is that Transtuzumab does not cross the blood-brain barrier and it does not work on central nervous system. So there is no benefit in brain metastasis. Other visceral side, it has a greater benefit, 2% in Transtuzumab arm as compared to 4.8% in observation arm. And similarly in skeletal mets also 1.4% in Transtuzumab arm and 2.2% in observation arm. It has also decreased the breast cancer mortality 1.4% in which is not significant.
Next one.
This is the now I'm discussing the updated 11-year follow-up of Transtuzumab, which is published in 2017 in February. It is also funded by Roche, and this trial has given information to us about the updated benefit of HER2 positive, whether the Transtuzumab this trial has defined whether the Transtuzumab has benefit for 2 years or 1 year, which is more effective. So in this phase 3 trial, 5,101 two patients were taken, which is HER2 positive breast cancer, according in 39 countries from 2001 to 2005, which is the older trial, and it is the updated version. Now in this trial, this is the schematic diagram of this updated analysis. Same as HER2 positive breast cancer were taken, and same as I had discussed, surgery, adjuvant or neoadjuvant patients, and radiation or without radiation treatment were taken in updated analysis. The inclusion criteria are HER2 positive breast cancer which are IHC 3+ positive by FISH or ejection fraction more than 55% are taken in this trial. These 5,102 patients were randomized into 3 arms. Again, 2 years of adjuvant treatment, 1 year of adjuvant treatment, and observation. In 2-year arm, the 1,700 patients are taken. Similarly, in 1-year arm, 1,703 patients are taken, and in observation arm, 1,698 patients are taken. Now, in this schematic diagram, there is one peculiar feature, that some of these patients which are in observation arm are jumped into the 1-year arm because of a benefit of Transtuzumab. So this shows some bias, like these patients are jumped into this trial because of beneficial effect of Transtuzumab. This is the table showing the demographic profile, which is equally matched. Most of the patients in this trial were in the age group of 35 to 49. Most of them are post-menopausal patients, which is the same to be taken, has most benefit in post-menopausal patients. This is the main Kaplan-Meier chart of showing disease-free survival in hormone receptor positive patient and hormone receptor negative patient. The most of the benefit seen in hormone receptor positive patient. This is the disease-free survival showing in hormone receptor positive patient. The blue line is observational arm. The red line is 1 year Transtuzumab arm and 2 year, and purple line is 2 year Transtuzumab arm. So this chart shows that hormone receptor positive patient has most benefit in arm with Transtuzumab of 1 year. Similarly, this Kaplan-Meier shows the benefit of Transtuzumab in node negative, in hormone receptor negative patient, but it is not as beneficial as in hormone receptor positive arm. This is here you can see the it has most of the benefit. The purple, the red line shows that it crosses at around 6 months. It has gone upwards towards the against the purple line. So this Kaplan-Meier defines that there is little benefit of hormone receptor of Transtuzumab in hormone receptor negative patients, because this may be due to that in hormone receptor positive we are giving tamoxifen or letrozole lifetime. So there is cover of that hormonal treatment beyond 1 year of treatment. So this may be the reason. This is the chart showing the site of disease free according to the hormone receptor positive patient and hormone receptor negative patient. This chart clearly shows that there is a major benefit of Transtuzumab in regional recurrence in hormone receptor positive patient, which is 1.5% as compared to 0.18%. Significant benefit. Similarly, in hormone receptor negative patient, there is little benefit, 1.9% versus 1.3% patient. Similarly, contralateral breast recurrence in hormone receptor positive patient, there is almost 1.6% in 1 year of Transtuzumab, and there is 2.5. This is also significant benefit. Then hormone receptor negative patient, there is in 1 year of Transtuzumab there is 3.3% of recurrence as compared to there is no benefit in hormone receptor negative patient. The major benefit of 1 year of Transtuzumab therapy is seen in contralateral breast cancer in hormone receptor positive patient. There is also a benefit in the death due to the disease. There is also benefit around 1.2% in 0.7% is, but it is not major benefit, not significant. Now the discussion, what is the crux of this 11-year update? The major benefit of this trial is that the relative risk of disease-free survival is reduced by 24% when Transtuzumab is given in 1 year. So, and there is 6.8% of improvement in 10-year disease-free survival in those women who were randomly assigned to 1 year of Transtuzumab. There is 6.5% absolute gain in overall survival at 12 years between those in 1 year Transtuzumab group and those in observation group. So there is clear benefit of Transtuzumab in all aspects. Transtuzumab was significantly greater during the first 24 months after randomization than during follow-up, a finding which might be partly attributable to crossover, which I had discussed earlier. Most of the patients have crossover from the observational arm. In subgroup analysis by tumor hormone receptor status, two important observations were seen. Overexpression of HER2 oncogene hormone receptor status remains a powerful determinant of disease outcome, with more recurrence and death in women with hormone receptor negative disease even after 11 years of follow-up. So this is the two trials which I discussed for Transtuzumab. Updated analysis clearly shows the benefit of Transtuzumab in disease-free survival, in delaying skeletal events, in delaying progression of disease, in contralateral breast as well as in distant recurrence and local recurrence. Thank you.
Many thanks for such a educative presentation, Dr. Gaurav. It was very informative. We have a complete overview of Transtuzumab, where it should be used and how it should be used. Now, and Dr. Richa, would you like to add something?
What were the side effects? What are the main side effects in the this study?
I think we have to be concerned about cardiac toxicity only.
Cardiac toxicity is the main concern in Transtuzumab. So the protocol is that in every three cycle of Transtuzumab we have to do echo.
Yes.
To after every 3 cycles, whether it is in 3 weekly regimen. In weekly regimen it is different. We have to go for after 6 cycle we have to check echo.
Yes. Okay, so the crux of the presentation is that for all HER2 positive breast cancer, Transtuzumab should be and must be used. It's a recommended and evidence-based treatment for HER2 positive breast cancer. In India, we are using Transtuzumab from 2000 to 2005 onwards, but the only limitation was the finances, the cost of the drug. But now, from the past 2-3 years, it's quite in reach of a common person. So the crux of the story is we should get the robust HER2 positive testing should be done, which should be done in all phases of treatment, in biopsy specimen as well as this resected specimen, and in presence of recurrence also, because the hormone status may change and may cross over. Positive may become negative, negative may become positive, and Herceptin, only the one most important precaution we need to see is to have a to assess cardiac status of patient before starting chemotherapy and while during the treatment also. So I would like to thank Dr. Gaurav for such a nice presentation.
Thank you, sir.
We had very good knowledge of Transtuzumab now. Okay, so looking forward for such educative presentation in time to time. We are from Radiation Oncology Department, Government Doon Medical College, Dehradun. Many thanks.
Thank you, sir.
बहुत